Well, good morning, everyone. Thanks for coming to my webinar, and thank you, Marilyn, for setting this all up. This is my second webinar. I'm not very familiar with how to do these things, so please be aware that there might be some glitches and things like that. Bear with us, and I will let's all hope that we don't have to do webinars for too much longer. I'm going to do this now because this is a appropriate thing to do. I did start with the mask. I want everyone, when they're going out and about, to keep wearing their masks, because it is a time that the COVID is still occurring. And I would urge everyone, once you get in line, if you can get the vaccine, then we'll be able to actually have these meetings in person. I've done various workshops at my clinic up here on Borland Road in Tualatin, and it's obviously a lot easier to meet people and greet people in person and to talk about their issues personally, which is much easier than doing it on Zoom, even though it's wonderful we've got this technology. So once again, my name's Paul Kane. I own Summit Physical Therapy on Borland Road in the Tualatin Professional Center. And the purpose of our meeting today is to talk about knee pain. I'm going to go out on a limb and think that the majority of people that are listening in today and watching me have got or have someone that they know with some sort of knee pain. So this is what I propose. I'll go into talking about the knee, which I hope you can see right here. This is a model of a knee, life-size model. There's my knee, and you can see it right there, hopefully. And then we'll talk about the types of conditions and painful diseases and conditions that people get with their knee, and then what we can do about it, what you can do, which includes physical therapy, self-exercise, and then stuff orthopedic surgeons can do short of surgery, and then of course surgery as well. I suspect a number of you may have had surgery on your knees in the past. A lot of people usually have history when they see me that they had something like an arthroscopic or a scope that goes into your knee and cleans it out. And then maybe you've gone on to have more degeneration, and some of you out there may well have had knee replacements, and we can talk about that. Some of you may be looking to getting a knee replacement. I'll go over some of the anatomy and what to expect when doing that as well. Others of you may just well have some painful knees where it's sort of walk or painful to go downstairs, upstairs, and you're just wanting a little bit of advice as to what to do about that, and I'll cover that as well. And we have an hour to do this, and like as Marilyn said at the end, I'll be fielding any questions that you have about your own personal knee conditions or general questions on anatomy and things like that. So the knee, it is really the largest joint in the body, and it's kind of the most complicated. If you look at it, it contains 3 real compartments. If we look, can you see I'm going to come closer. There is the kneecap. This is this guy here. He's in the front of the knee. You can reach down and touch your kneecap. Maybe all of you can do that. When you touch it, you can feel it gliding, right? How's that? Good. Now that's a real big generator of pain. You can imagine underneath the kneecap are the bones that the kneecap slides in. And when we go forward and back, the knee slides. And especially if we tighten the big muscle up here, the kneecap pushes down onto the groove. So you can see that. And a lot of us out there might have what we call patellofemoral pain. The kneecap's called the patella, okay? And it slides in its groove. Now, we'll talk about the other parts of the joint first, and then we'll go back to the conditions that the parts of the joints involved. So the next thing is what we call the medial, or the inside part of your knee. This is looking at it from the front. So if this is your right knee, we're talking about the inside of your right knee. Does that make sense? So you can touch the inside of your right knee right now. And if you're sitting down, like I presume most of you are, you can actually bend your knee. And when you touch the inside of your knee, right about there, I don't know if you can see that, you can actually feel the joint open up. You can actually put your finger and feel a little gap between those two joints. And that gap is between the femur bone and the tibia bone. And this gap here contains, I don't know if you can see it, do you see that red stuff there? That's called the meniscus, or the cartilage. And you've probably all heard about meniscus, or I've torn my cartilage or something like that. And again, if I come a little closer, you can see these cartilages lining the top of the tibia bone, which is your leg, bottom leg, lower leg bone. It is on the inside and the outside. And if we look in there, you can see that they're kind of semilunar or circular shaped. Now, those are things that are really important. If anything goes in your knee, the most common thing in elderly people, and I'm just going to presume the majority of you are elderly, because it is Juanita Pohl Senior Center, is the cartilages. And what they tend to do is they tend to tear. And they tear often because of twisting. So when you were a younger person, even older, even in your 40s and 50s, when you ever got into a situation where you stepped wrong and your foot stuck, or if it twisted on mud, or if your body was moving while the foot was staying stationary, playing tennis is a big one, sometimes golf, your leg twists, and that can pull and tear on the cartilage. And the bad thing about the cartilage is it's not very well supplied by blood. It actually, only a portion of it is. And so these things don't heal very quickly. So what most doctors do is, if it keeps catching and twisting and things, they'll talk about going in, and I'll talk about meniscectomies and things in the future. So that's called the medial, and that's called the lateral joint line. Okay, so there's three parts to your knee from an orthopedic point of view: the front, patellofemoral, the inside, medial, and the outside, lateral. Okay, so let's talk about what the conditions that affect people on a basis of kind of like most common to least common are, and I'll go over that. The first ones that we could probably talk about is muscles and tendons, and what they can do to cause pain in your knee. So you can see this red stuff here. That is actually one part of the big muscle in the front of your knee, and I bet you all of you might know what that's called. Have you ever heard of the quadriceps? Okay, and quadriceps means quad, 4, ceps means head, and so it's got 4 heads, meaning that it actually has 4 attachments, 4 actual pieces of muscle. The one that I've got here is there's only one of them. Notice it comes down and goes right down here into a bone on the front of your knee, and you can actually feel that. You can press down and push down about an inch below that bottom of your kneecap, and you'll feel a bump. Some of you may have a really big bump, and that's a condition that you got when you were kids called Osgood-Schlatter's, and that's sometimes painful when you're growing, but it usually settles down when you get older. And I just presume that none of you listening in here today are 15 years old with that, but that's another bony condition that can be caused when you grow too quickly. But anyway, so this between the knee and the bone of the tibia is a tendon. So muscles attached, muscles become tendons, and the tendons are the things that attach to the bone. And the biggest thing that the quadriceps does, probably the strongest muscle in the body, is it actually allows you to walk and run by straightening your knee, okay, by straightening the lower leg. So every time, if you can reach down right now and tighten that leg muscle, you'll actually feel the big thigh muscle contract. And what it really does, as you know, is it straightens your knee. And that's one of the most important things to do when we walk and we run. So tendons, what can they cause? Well, in here, it's a common place for people to have pain right below the kneecap. So if anyone out there right now is sitting there and they feel they put their leg out straight and they feel their bone, their kneecap bone moving relaxed, and then they just push their finger right below the kneecap and it hurts, then there's a good chance that that tendon has pain. Does that make sense? But oftentimes athletes have a thing called jumper's knee or patellar tendonitis caused by too much jumping and not enough strengthening. It's not that common as we get older, but I do see some of it manifesting in some people that I see. The good news is there's things you can do about it. And the best thing you can do on all of these conditions is self-care to start with, simple stretches and gradual increase of activity. And second thing is get some physical therapy, making sure that the therapist knows how to progress your treatment and make sure that they do a good study of how strong your muscles are and how flexible they are. Because think about it, if you've got a very weak muscle up here, it tends to get smaller. It tends to do what we call atrophy. And what that means is that when the tendon comes over, and this muscle is all shortened and shrunk and atrophied, it can actually push the kneecap down into the bone because it's weak, creating problems in the kneecap caused by weakness in the muscles and tendons. And the first thing we can do there is get you to go get a bit stronger through activities and exercises, and then also stretch the muscle to make sure that it doesn't put pressure on that kneecap. Does that make sense? Any questions personally? You can, Marilyn can give you my address and things at a future date, or just remember Summit Physical Therapy, and I'm on the internet and my phone number as well. So I'll talk about that when we finish. So kneecap and jumper's knee, that's one that's quite common. People might have some problems with that. The next thing is what we call medial joint line pain. And I talked about the meniscus and the cartilage. And what happens, unfortunately, is if you get surgery and the cartilage is taken out, or the doctor goes in and he puts a scope and he puts a little trimmer and he burrs it all out, it actually makes less of that shock absorber available. And what happens is these things are just shock absorbers. What they do is when you go like that, when you're running or walking and it goes up and down, they are like shims, like rubberized pieces of shims, just like in a car or in a piece of equipment, and they are designed to stop hard surfaces from hitting one another. That's exactly what the cartilage does. If you get a little bit of that shim taken out, then the chances are that you start getting bone hitting bone more. Now, the funny thing about that is that a lot of people have very bad cartilages and they still don't have a lot of pain. And I've seen people with that. They come into me and they've got this very big grinding, it feels, and some of you out there must have probably grinding when you go to take your knee through a range of motion. Some of that could be on the kneecap. Some of it could be deep in the joint. And I go, oh, that must feel awful. But they say, you know what? It doesn't really hurt. And that's good for them. And the reason it doesn't hurt is that there's another special form of cartilage that lines the bones. Has anyone out there, do you eat chicken? And if you eat chicken, have you ever gotten a leg bone of chicken and you've pulled it off and you've seen, and you look at that and it looks kind of like this, but much smaller. And if you ever noticed, the next time you eat chicken, I suggest you look at it, take a look at that joint, that leg bone that you just tore up. And you could actually take your fingernail and put pressure on that joint, and you could even dent the end of that bone, okay? And the denting in the end of the bone is that liquid latex. That's what I would call it. It's a cartilage that lines the bone, okay? So you can see on this, it doesn't really show, but this would be lined with what we call liquid latex. And you could say, I could put my fingernail in that, and that would actually make a dent in it. Now that's healthy cartilage. And what happens is that it's the last line of defense between that bone hitting that bone and being bone on bone pain. Some people have a good amount of what we call hyaline or articular cartilage lining the bones. However, once with age and genetics and being out of shape and things, that bone can become worn out as well. And then we start getting that deep grinding pain that I'm sure some of you out there have had. And at that point, it becomes much more harder to treat with physical therapy. But before that happens, the most wonderful thing that nature gives us is the ability of our joints to remain healthy by movement. So simply moving every joint, and especially in this case, the knee, through a range of motion, lubricates, washes out the joint, brings in nutrients, and takes out waste products by movement only. And that's because we're designed to move as animals. Mammals, we are one of the best long distance runners. So my little aside is I run, I now ski and I bike. And yes, I've gone through my fair share of knee pain as well. But what I do is I certainly can, I'm changing to more biking than running, but I have used my body as an experiment. And once I've done a few exercises and looked at my form, I'm finding that my running is now getting better again because I've kind of analyzed what I was doing wrong. And I've taken some time to self-mobilize my kneecap especially, and then gradually increase my running again. Plus, I now know to ski, how to ski a bit better. So, all right, a couple of other things that we would find out about what might cause problems in your knee is some of you out there might have been athletes and had some old injuries, car accidents. And if you look deep underneath there, you can see these what we call ligaments, called the anterior and posterior cruciate ligaments, which are deep in the knee joint that stop movement backwards and forwards. And that's another athletic injury that happens when people are on the football field or tennis or something where their lower leg stops and the upper leg keeps going and they tear this way or this way. Does that make sense? Or they can have a twist. Some people get 3 injuries in the same fraction of a second, and they actually tear this ligament and the deep one in there, the anterior cruciate, because it all got stuck in a terrible way. That requires surgery. They've got great surgery techniques now, but down the line in the future, decades later, you can have wear and tear from the actual area where they put in the new ligament. That's kind of a whole nother subject. If anyone wants to get information about that, call me later and I'll give you information or talk to you about, the ligament that they might have put in to replace the tendon that was torn. Or the tendon they put in to replace the ligament that was torn. The next thing is what other things that might cause knee pain that might not really have anything much to do with your knee, surprisingly. So a couple of things, but by the way, the ligaments on either side of your knee stop your knee from doing that and stop your knee from doing that. And you can see that they are there designed to bind your whole knee together to stop it from moving around like a jigsaw puzzle. That's called the lateral collateral ligament and the medial collateral ligament. And that can be, as this one is actually tearing, they can be torn as well. They don't usually have any surgery. People do quite well with torn ligaments. They just are a little bit unstable, sometimes need to wear a brace, okay? All right, couple of other things. Outside of this knee, when you're in the muscles, there is a band of tissue that comes across and along the outside of your leg. And you can feel that sometimes when you bend your knee and straighten it, you can feel a pop or a click that might not feel like the joint. And that's probably a little band of tissue called the iliotibial band comes along and inserts up here. That is more like, again, a runner's injury. It can become a problem if it keeps snapping and popping, okay? Usually a good therapist can show you 2 or 3 stretches and 2 or 3 exercises to completely get rid of that, okay? And I say, and again, the hamstrings muscles coming from the back of your pelvis down to the back of your leg, if they're really tight, they can put pressure on the back of your knee as well. Most people should be able to lie on their back, bring their leg up, straighten their knee, and get somewhere near to 80 to 90 degrees. And I suspect as we get older, we tend to not really do much stretching of our muscles. And that's another thing that I find when I work with people in here, that really a lot of their problem is that their muscles are really tight, which means that they push down on the joints. The more strong the muscles are, the more they support the joint, okay? So getting back to the things that I think, the majority of us elderly people have, is kind of like degeneration, wear and tear, and we wake up painful, okay? We have real trouble going up and down stairs or walking for more than 100 yards to half a mile. Those are the conditions that I see a lot of. And so the first thing you want to try is stretching yourself and mobilizing your kneecap, which is, can you see my knee? Mm-hmm. You can take your knee and you can just push on it, round and round, up and down. Sometimes that can be quite painful. Persevere with it, stretch it. Okay. You can do any variety of stretching of your hamstrings, or as I say, and I can't lie down in this forum, but stretching by taking your knee and stretching it, and especially stretching your quads. Can everyone see that? I am taking my leg and I can actually get my heel all the way to my butt, okay? Now, I doubt if many of you can. My muscles, which are, get used quite often, they really need that. If I don't stretch my quads well, I can feel it, okay? So there's some examples. There's some examples how to stretch the muscles along the side of the leg as well. Again, a little bit difficult to show you in here in this forum. Now, what about strengthening? Okay, sometimes the best thing to do in strengthening is simply to sit and just tighten that quad muscle. Just do exactly what I'm doing. Tighten that muscle. Hold it there. Especially feel about tightening the inside part of the muscle. You can't really see it here, but when I tighten it, do you see that my finger is kind of rising up? That's because this muscle is tightening here, and it's really important to get the inside muscle tightening. It's really important also to do a number of what we call closed chain exercises. And what I've done is I've given, this is just 2 inches high. If people want to start just by doing this, this is fine. Nice and slowly. For people that are suffering from knee pain and they can't do a full step, start like that. You'll be firing that muscle and making that joint actually be more supported.
So the sore knee is on the board? The sore knee?
The sore knee is on the board. Good question. Yes, of course, it's the one that you're exercising is the one that is up on that. Here's another one. This is now 4 inches. Look how slow I can do it. See how many of you can do 2 sets of 10 of a nice slow lift. And a normal stair is 7 to 9 inches, usually 8 inches. I can do it quite easily. I suspect many of you would not be able to do that. It's better to do the 4-inch one, okay? That would be an example of a closed chain exercise. Followed by, again, stretching. And we can lie down on your tummy and stretch. I have these stretch out straps for people that can't bring their heel anywhere near their butt. And we just slowly work on stretching it.
Can you use a chair?
You can use a chair. Just standing, holding it there. You'll feel it stretch. This is the stretching leg, of course. And you can take it from there. So the stretching the quads is a good idea, okay? One other thing, a lot of the pain that you get in your knee can be coming from what we call imbalance. Women especially tend to be a little knock-kneed because of their hips, because they have babies, thankfully. And so when your knees come in like that, you tend to put an angle like that, which puts pressure on the outside of your knee. And that's, again, when you do that, because you're knock-kneed, that joint gets down there. And a lot of people, women, have pain on the outside of the knee. A number of you ladies out there might be having that problem. That's an issue where we can do a little bit of playing around. There are some orthotics that, of course, if your feet go from like that to being supported, it can conceivably straighten out and give you a bit of a help there. The other thing is your hips. People that have knee problems often have weak hips. I spend a lot of time working on hip strengthening exercises because a lot of the problems we have when we walk are because of muscles up here being weak and the quads and the outside muscles being overworked. And so I would say it's a very good idea to do some hip strengthening exercises. I give rubber bands to people and have them walk sideways, the ones that can do that. I get people to lie down on their side and lift their leg up from the side, sometimes even against a wall to make sure they're in line so that they can work these muscles up in here, which are really important for the hip. So a couple of other things we can talk about. There are braces that you can use if you get to a stage where you're not, where you're having pain no matter what. The first type of braces you've all seen are the sleeves that you pull on, get them from Rite Aid. They're often like Ace or whatever. They can be helpful in the early stages. Other ones have little hinges along the side, and they prevent you from hyperextending, we call it, which is being unstable and going backwards accidentally. They can be helpful. They're not that expensive either. They are worthwhile if you have real weakness and you talk about, my leg went back and I had pain. And then there are really specialized braces to see if they can help this problem, which is the outside of the joint because of the knock knee. They can put pressure on one side and the other side to do that and to actually gap the joint. They can cost from $600 to $1,000, and I don't know about insurance paying for them. That's a whole subject that you need to be analyzed and fitted for if you're paying that sort of money for a brace like that. It needs to be fitted right. And the problem with braces is if they're not comfortable, if they slip, or if you've got too many straps and it's really hard to put on yourself, and fingers are a problem and things, they often are really, people spend a lot of money or they get it paid for and they don't use it as much as we would like. So they do have their place, but the person has to be really willing to do it, and it has to be tried and fitted right for them. So another option there. So what else? We've got good timing. That's good. There are plenty of people out there that say there are things you can do that is not physical therapy. And I'm sure some of you who suffered from knee pain would like to know about stuff like injections, and what is all that about? So generally I'll go over the things that from an orthopedic point of view they might offer you. The first one is cortisone, or a steroid, which would be usually injected into the joint line or into the top of the kneecap or into the areas which contain a bursa, which is a fluid-filled sac that lubricates the joint, which there's one up in here behind the kneecap, but above the kneecap. There's one right on top of the kneecap. There's one right underneath of the kneecap. And all of those can cause swelling and pain. And but mostly doctors offer a cortisone injection into the joint line. And they're very valuable if you're, say, older and you know that your joint is giving out and you want to go for that on that trip to Europe or whatever, once COVID is finished. And that allows you to walk around the cobblestones of Europe with much less pain. It is true, though, that it's just masking the problem. Cortisones are really powerful anti-inflammatory, but it works by actually ultimately sucking blood and decreasing blood flow to a joint, which means that nutrition is damaged. And so all orthopedists will tell you this, they don't want to do multiple cortisone shots because it will just hasten the arthritis. And so cortisones, that's what a general orthopedic will do. Now, recently, much more exciting things have come around in terms of regenerative medicine. And well, they'll offer you, firstly, a thing called Hyaluronic Acid, or brand name Synvisc or Orthovisc or other brand names, that is derived from usually animal, like one of them is from the rooster cone. But anyway, what they are is a liquid cartilage that is really a lubricant, and they'll inject that into the joint. And it's quite good. There's been some good research as to its benefits in the early stages of osteoarthritis. It works well. Think about it. If your fluid in your knee is not being produced very well, it can be a nice additive to be like a lubricant. It's like putting in machine oil into a seized engine. It can be very beneficial for that. But it's been proven not to be worthwhile in advanced arthritis of the knee. So you pick and choose what you are when you go to a provider, and make sure they know, or that they've analyzed how damaged your joint is. Recently, there's been some really exciting involvement of what we call injections of PRP, which is platelet-rich plasma, and even more science fiction, stem cells. So firstly, platelet-rich plasma, they take your blood and they spin it, and they take out the quote good stuff from the inert stuff, and then they re-inject that back into your joint. They used to do it, they began by doing it into tendons, most notably that tendon, with good results in a number of people, because it seems to hasten the healing of the damaged tendon. And more recently, they've taken to doing it in other parts of the joint, including the joint space as well. And the research is out a little bit. They need more study on finding out the benefits of that. They are talking about, insurance does not pay for that yet. And so that's eventually, if there's a real benefit, then insurance will pay, you would hope, for the benefit so they can keep away from the expensive surgeries. And then stem cells are an interesting thing. Whenever we're finding that cells, when we develop, do not become the specific cells until they've been programmed to do that. And if you can take cells that are that have not been programmed to become, a brain cell or an eye cell or something like that, you can reprogram it. And in this case, hopefully you become a cartilage cell. And so that would be the holy grail, for them to be able to inject in a bunch of cells that will actually grow into cartilage. And again, preliminary research, we're really having to wait on that. People are doing it, but I don't know how much they're saying, are they guaranteeing success? They're absolutely not. But stay informed. This may change with more research. Okay. So that gives us a little bit of anatomy of the muscles, joints, and tendons. Some advice as to what to do yourself, the stretches and the strengthening. Stretching of the quad and the hamstring, the iliotibial band, strengthening your quad muscle, okay? And strengthening in the hip, which is often a real beginning part of the problem. Let's talk briefly about surgery and what they can do. And the first thing is it's remarkable what orthopedics has come to now. It's been only 55 years since joint replacements have been available. So in the rest of human history, people just suffered. They ended up in wheelchairs, and they ended up hobbling along on crutches before they died, because nothing could be done. They did a study actually of doctors. They did a questionnaire. They said, what has been the biggest breakthrough on medicine in the last 100 years, I think, or at least the 20th century? And the answer, joint replacement surgery. It's helped more people than curing polio and things. So that's pretty remarkable, isn't it? And it keeps getting better. You'll find that I know this for a fact, that people that have had knee replacements for 20 years, they did not get a knee replacement put in them that was specific for them. They got it that was a kind of generic off-the-shelf replacement that was like, oh, he's big, he's small, and they're medium. And of course, people come in all different sizes and shapes. Nowadays, they have it it's computer generated to be the shape of your bones, okay? People might ask, and I'm sorry, I don't have an actual knee replacement, but I know the orthopods do if you go to visit them. It shows a metal covering on this, a metal covering on this, and it looks icky, but a great big implant that goes all the way down into the bone, all the way up into the bone. And plastic covering here, which is what plastic here, metal here. And what happens, and then people don't want to know, do you have a kneecap left? And the kneecap is actually preserved. Your kneecap's there, but they put a little button on it so that it can run in its groove. Okay, and you then come out with a completely new knee, and it takes 6 months to a year for you to feel really, really good. Some people are lucky, they feel good after 3 months, and they take that questionnaire to say, are you happy you did a knee replacement, about a year later for that reason. And 90-something percent, 95% say they were happy they did it. Some of them have had a rocky road recovery-wise. I treat knee replacements all the time. And I find that that there are some people that come out with a nice loose knee and a good scar from day one, and others struggle and they have swelling and they're warm and they have all sorts of problems. Majority of people are doing well and doing good range of motion and getting stronger within 2 months of physical therapy, which you must have after a knee replacement. You also, have a possibility of doing prehabilitation, which is coming in and seeing someone like me who goes over the exercises you can do before you do the surgery so that they're in the best shape for after surgery, because the muscle's been all cut and stitched back together again, and it'll get weaker, and the stronger it is before you go in, the easier the rehab is here at our clinic. Briefly, I'm in a room in my office. My gym is right outside. Anyone can feel free to come in and tour my gym. I have a lot of exercise machines out there, including what we call plyometric rebounders and shuttle machines that allow us to start off very easily and gently and then get to more and more strengthening. We have 2 bikes out there as well. A bike is important to get the range of motion, but you don't want to do it in the first day or even 1 to 2 weeks. And in some doctors, 3 weeks before getting on the bike. It can cause more trouble than it's worth, but it's really good otherwise. And then we gradually get on to functional activities like going up and down stairs and balance exercises as well. So I hope that brought around into kind of giving you advice and information that is valuable for you. It's about 1:45. We have about 10 to 15 minutes that I want to give a lot of people time to formulate and ask any questions. Marilyn, are there any questions at the moment? I wonder.
Hi, Paul. Yeah, I'm here. Sorry. We don't have any questions in the chat or in the Q&A function yet. If anybody wants to, they can go ahead and type those and I will read them aloud.
Sounds good. And in the meantime, I can kind of keep talking and Marilyn can interrupt me if a question comes in. I want to emphasize that the best thing that you can do for your knees is walking, and walking is what nature gave us to enable us to get around, and therefore, obviously, if walking increases pain, then we got to think about doing things that is still walking that may lessen pain. And unfortunately, COVID has really interrupted the gyms that have swimming pools, but it would be good to think about getting to a swimming pool again once they're open. Maybe some of you are rich enough, you've got an underground pool in your house, but I doubt it. I have a lot of people that get benefit from water walking, underwater treadmills, and things. Biking on a stationary bike is good because it's non-weight bearing, but it's still good to lubricate the joint. Anyone who's suffering from knee pain, investing in a stationary bike is a really good idea. starting out a walking program, if you hurt after, say, 100 yards, then go 80 yards. But then say, okay, I don't hurt, I'm going to stop, but then tomorrow I'm going to do 90 yards. And it's really impressive that sometimes you can increase your distance in walking by just being consistent in saying, I'm going to walk right up until the point of my pain, I'm going to stop, and then I'm going to be consistent, and you can walk a little bit further each day, which means that relatively soon you're up to walking 400 yards or even, a couple of miles.
Paul, we
Going
have a
up and down.
question.
Okay.
The question is, how do I determine if a physical therapist is good and knows what they are doing?
Yeah, that's a really good question because, a therapist can put out a whole bunch of letters after their name saying, look at me and what I've done. You know what you need to do? You need to interview them. You need to find out if they're a comfortable fit for you, because that's probably the most important thing. And a person can be the best physical therapist, just like in any profession. He can be very learned, but does he relate to you? Can he answer your questions? Is he the one that can motivate you to be to take you through what you need to get through? And I suggest you actually phone the person and even request a short meeting. I do that all the time. Any therapist that is certainly in private practice and even in the hospital setting should be able to take 5 to 10 minutes out of their day to introduce themselves and ask you what your problem is. Ask you, what is the problem with you? Can I see that and what I would do about that? So don't be too, into things like credentials and all that. It is how comfortable you are with them. Do you feel that you have a rapport with them? Because honestly, a lot of strengthening and stretching is not rocket science. It is getting you motivated to do the things that help you. Okay?
Great. Thank you, Paul. We have 2 more questions. The next one is, when using a stationary bike, I assume some fatigue is okay, just stop when there's pain or before the pain surfaces. Is that correct?
Yeah, good question. So there are always variables when doing any exercise, including a stationary bike. When that person that wrote that question says fatigue, I presume she means fatigue means that the muscles feel like they're tired, not pain in the joint, but the muscles are tired. So there's a few things. Speed of movement, like if I got on a bike and I went at 120 revs per minute at the highest setting, even I would get really tired and fatigued. Well, no duh, what I would do would be reduce my cadence and reduce the resistance. If she's saying, I don't know the questioner's name, but if you are on the lowest setting and are going slowly and still get fatigue, then it is a tough question. But I suggest you look at changing a couple of those variables, seeing if you are, if you slow down and be more relaxed, that could help the fatigue. Or some machines actually work on a dynamo, and actually if you pedal faster, you get actually less fatigue because the resistance gets less, and includes one of my bikes out there. And people that go really slow, there's more resistance. So there are some variables you can try, okay? And if not, give me a call and I can walk you through that.
Great, thanks, Paul. We've still got a couple more questions. So the next one is, 2 months after twisting my knee in a fall, what is the best exercise I can do? My knee hurts inside, especially when I lift my leg, as in getting into bed.
Right. The caveat on a question like that is that it's really difficult to answer an individual question about an individual injury type of scenario by giving you a generic answer and making and finding out that it may not be good for you. I'm going to kind of punt on that to a little point and ask you if you could call me 503-699-2955. We'll put the Marilyn can shoot you my phone number and website and anything else, and you can email me if you want to, so that I can answer that question specifically. Because if you could imagine you twisted your knee, you may have something wrong with the cartilages in the middle of the knee. Saying what is the best exercise for that is a bit complicated, because I don't know what your knee actually feels like and what is going on in there. You do need someone to take a little look at that knee, I would suggest, because you're suffering still after 2 months. It's unlikely that that's kind of going away. Would you agree?
Great, thank you, Paul. I will definitely include your information when I send out the post-webinar follow-up, and I will also include a link that will have this video in it for anyone who wants to read anything that was said. We still have another question. This question is, what is your opinion on natural remedies for flexibility or pain management, icing versus heat, etc.? Oh,
well, good question. And I apologize, I didn't really go over that, did I? So the old standard 10,000-year-old remedies for joint pain are ice and heat. They have different purposes for different times. Of course, if you fall or you twist or you do something and your knee swells up and gets warm, then of course you've done an acute injury, and ice is by far the best choice for that. You want to get it wrapped around fully around your knee. There's plenty of flexible cold packs available at the store. And you can just do the old standard of crushed ice from the fridge, crushed up in a plastic bag and wrapped around your knee as well for 15 minutes. Don't do more than that, because then some other things can happen, and do that 3 times a day. Heat is much better for people that are really stiff. Although heat is a superficial issue, superficial problem. It's a superficial help. It can be very helpful to loosen tight muscles, and it can be good for like forms of arthritis that respond to warming up. But I often go into a combination of ice and heat about 6 days post-injury if it is a real injury. The question that she had was natural remedies. It might include things like naturopathic rubs and medications and stuff like that, even CBD, which is now flavor of the month and legal. I think that it's best to, anything can help anyone. There's a big, what we call placebo effect. If you believe it's going to help and you rub it on, it can really help you. Which are, a well-studied phenomenon. In terms of like, there is something about things like arnica, which is a natural remedy, which does have natural anti-inflammatory products and other things that are like that. And I'm first to say, give it a go, try that. A lot of our anti-inflammatories, by the way, ibuprofen, aspirin, acetaminophen, they all have their places to as well. And they all came initially from the natural world. And so don't discount taking a good dosage of NSAIDs, non-steroidal anti-inflammatories, in association with the ice if you've had an acute injury. I think I can say that confidently because those are over the counter. In terms of anything that's prescription, I can't answer that because I'm not a doctor.
Great, thank you, Paul. I do have another question. Let me see here. It's a middle long one. Okay, my knee is very sore and stiff if I leave it bent, like when sitting. It warms up eventually and pretty quickly. It also hurts first thing in the morning with even light pressure, like pushing into my shoe. This joint started after working fine for a few 7-mile hikes, but then felt swollen and sore for almost 2 months since. I'm 61 and with some arthritis, but this feels swollen. Do you have any advice for that person, or should I include your contact information to answer that question?
Yeah, please include my contact information. I'd be happy to talk to them at a time we can agree on. But it sounds like you've got it again. It depends on exactly where. You did kind of give me an idea of where the pain is. I think you're saying it's more anterior. It happens often when a hike occurs because you're going up and down hill and putting weight on the front of your kneecap. I personally have had that myself, climbing some of the mountains around here. Hopefully you did do the ice compression and elevation, and especially ice. It sounds like if it's still swelling, then there's still some active stuff going on there. I would continue to do ice. I would go through some general stretching exercises the way I showed you, and I would avoid, and it sounds like it might be painful going up and down stairs. It might grind and crack. You might be talking about what we call patellofemoral arthritis stuff. It probably needs to be looked at, get some professional advice. Does not take long to get you on the right track there, okay?
Great. Thank you so much, Paul. We have just one more comment, and then I think it's about time to head out. The comment is, your answers to my questions were great, and I appreciate your time very much. And I think I echo that sentiment. Thank you so much, Paul. As always, it's been a very informative class. I'm going to send out Paul's information to everyone. Yeah, I'm going to include your information, Paul. I'm getting questions specifically regarding some injuries. Paul at Summit, and I'm going to include his information, his email, his phone number, as well as his website. And Paul's been very generous with his time, and I'm sure he will continue to help us out with this for anyone who has any more specific questions. We are running out of time today. Thank you all so very much for attending. And especially thank you, Paul. Do you have anything last minute to say you want to before we head out of here?
No, thank you from me for everyone that attends. I hope it was informative for you, and I enjoy doing these things. Hopefully we'll be able to do in-house workshops, which I will offer once COVID restrictions are lifted and we all get healthy and we're all free of this, real, can I say, dreadful time that we've gone over the last year dealing with this. Then I will be able to host in-house workshops, in which case you can come and meet me in person.